to what will be the second international workshop on this methodology, which we're going which is going to take place in the first week of November in Mexico City, with a valuable support from the Collaborating Center for International Family Classifications, PAHO Collaborating Center, known as CEMECE. This cycle, this will be coordinated by Ms. Aline Jiménez, who is our international consultant from the International Systems and Platforms for Health unit within PAHO, which is part of a new department that PAHO just created to provide more importance and weight to health information systems and tendencies and trends that technology has made possible in this region. This department is called Evidence and Intelligence for Action in Health. Ms. Aline Jiménez has broad experience in Mexico as well as in other countries in the region, given that in her experience she was the Director of Information Systems within the Secretariat of Health of Mexico, and was also the Director of the Mexican Center for Family of International Classifications, CEMECE, as well as other areas of expertise and knowledge. Also, Mr. Manuel Yáñez, Director of CEMECE, will also join us and will share his experience in the methodology shared with countries in the region. We consider this session opened. We're going to describe shortly the methodology for this webinar and of your participation in the next webinar. All of your questions, all of this will help us improve the measuring of maternal deaths as well as the methodology. We've been all working on the question of maternal mortality. This search needs methodological support, and this methodology has been invaluable in this effort. Thank you, everyone. Ms. Aline Jiménez will now begin. Good morning, everyone. We would like to request everyone to please mute your microphones. Please close your microphones to avoid needless sound in the room. We thank Dr. Patricia Ruiz for her very helpful introduction and her presentation. On who I am, and Mr. Yáñez, both of us from CEMECE, who will be presenting today. Above all, I would like to personally thank Dr. Ruiz for her interest in this topic. Without this, it would be very difficult to disseminate this methodology, this important best practice. Without further ado, I'd like to begin the talk. If you have any questions or comments at all, please wait until the end of the session, typing it also into the chat session. At the end of the session, we will dedicate 30 minutes for answering all of these questions. Therefore, so please enter all your questions into the chat box. Thank you. The agenda for today, excuse me everyone, please be sure to mute your microphone. One moment, please. We request your help in please muting your microphones. Thank you. We will begin in just a moment, please. As we commented, we're going to review quickly what topics we're going to discuss. First of all, the importance of this topic. We're just going to give some context for everyone who's here. We're here because we know the importance of this topic. We're also going to discuss the challenge itself. What are we trying to address here? Next, we're going to discuss how these issues have led to the international estimations. We're going to discuss the best practice that the RELACSIS is working to disseminate through PAHO. And lastly, what is the importance? All of us know the importance of this topic. It's important to emphasize some critical points. We know that maternal mortality reflects the magnitude of a public health problem. As we all know, it's not only an issue of public health, that's an area that it's affected, but it also reflects problems from other aspects of the development of a given country. That's why maternal mortality is precisely a key indicator for measuring the development of a country. So it occurs also demonstrates problems of coverage, access, and quality of the health services. It also reflects problems in the quality of care. As it is widely known, the majority of maternal deaths are avoidable. Without mentioning that all these issues result in the fact that reducing it is an object of close international and national attention. We also want to emphasize that the maternal mortality indicator, as all of you know, is one of the main indicators included in the Sustainable Development Goals and the Millennium Development Goals before that.
In that sense, in order to correct such aspects of coverage, access, and quality of health systems, it's indispensable to measure the problem itself. And the sentence, what cannot be measured cannot be improved, fits perfectly in this case. However, in this case, we need to go beyond and not just measure. We need to make sure that we measure with quality and effectiveness this type of data. Because each maternal death that we identify will allow us to discover what were the aspects of access coverage that failed, in order to intervene directly in those aspects. In situations that measurement have been left behind, the errors that were committed in the health system for that maternal death to occur, we can almost ensure that won't repeat itself. If whenever the death occurred, a bad practice of the doctor was incurred because of human resources, if we don't identify this problem, this type of maternal death, it'll be almost impossible to identify that he or she needs this training, and whenever something similar happens, the fatality will happen again. So I would like to continue to show you the importance of identify and telling the story of each maternal mortality, and make sure that we understand the factors for this death, and that they don't happen again, in order to reduce these numbers. Well, I did not. I forgot to comment. I will try to make brief pauses, because for the first time we're transmitting this with a simultaneous translation, so it's important to give them a little break so they can work in a smooth way from the booths. So every now and then I'll make some pauses. Well, the most difficult part of having quality information about mortality is a worldwide problem. It's nothing new. It's not for only the countries within the region. Some of the causes are more accentuated in some countries, but it's an international problem. Same thing happens in Latin America, but also in developed countries. And we can mainly say that this hardship is due to two major factors. These factors are under registration and ill-defined classification. Under non-registration, we can talk about cultural factors that often determine if the deaths in general, of course maternal deaths specifically, are not registered. And I'd like just to include a caveat. Speaking of registration, I'm not talking about the coding system for the death itself. However, the way the data is collected about the disease or the death, and the systems that produce the official death information within the countries. So it's important to clarify this point. So we understand that cultural factors can be seen as breaches, geographical and cultural breaches. Also, the processes within each country is established to ensure that the death registration, sometimes these processes are too complicated, too bureaucratic, leaving some end losers, and sometimes one of these deaths just end up not being registered. For any circumstance on the way, in order to get to the health systems, they got lost. This type of data got lost. And last, the information source is being disconnected. So deaths that occur within a medical unit, maternal deaths, that most of them occurring within medical units, not only they're not captured within the systems, regularly the event is captured outside of a proper health system.
Therefore, if we could guarantee linkages between all these different sources of information, even if the death, for the reasons we mentioned, did not end in a death registration, we could still in some way get this information because we can obtain this from other sources, not directly from the death certificate. This is another issue that impacts sub-registration. On the other hand, emphasizing ill-defined cause of death. So what are the factors that lead to this? So here's a hypothetical case that the sub-registration was not affected this time. We have the death, it's reported, recorded, it's in the information system. However, despite this, there are still problems. The main problem, that there was an error when the death certificate was completed. This could be in part, and in some places, from the lack of understanding on the doctor's part in how to properly complete the death certificate. This could be a case in which the doctor does not consider it relevant to mention that the woman was going through pregnancy or that she was in puerperium, and this information is not reflected in the death certificate. So why not? So I would prefer not really mention it, and some of you might not want to hear this, but sometimes some deaths are deliberately hidden. This could either be because of political pressure from the labor force. So with ill intentions, the death is hidden and is not reflected as an obstetric death. The obstetric factors are not put on the death certificate then, therefore. To make matters worse, there are even some cases there could be errors in the coding process and the selection of the underlying cause of death. We all know that coders of the ICD play a critical role in producing information regarding morbidity and mortality in our countries. And we also know that their training is not always easy. They require being well trained always, and specifically in the issue of maternal mortality, the question gets even more complicated. Therefore, it's really important to make sure that coders of mortality are trained specifically on maternal mortality, because otherwise we do run the risk of that information being lost also. Please excuse, I dedicate a lot of time to this slide, but I think it's really important to emphasize this. So considering all these issues and the great challenges we have to address them, especially considering the impact that these problems have on the figures that countries report on maternal mortality, that at the end of the day, it demonstrates significant under-registration of maternal deaths that the countries report. The solution has been to use international estimations. That's why the Maternal Mortality Estimations Interagency Group was formed, also known as MMEIG. This group is made up of, its main objective is to correct sub-registration in each of the member states of WHO. It aims to give figures which are as close to reality as possible. This group, as all of you know, many of you know, it's made up of the World Bank, WHO, UNFPA, and UNICEF. The group produces publications every 2, every 3 years, where they publish these corrected figures. After applying a methodology which is fairly complex, so usually we're looking at a 50% factor increase as on average. Most of the countries often see their official figures multiplied because of this 0.5 factor. So 50% is usually added on to the figures that they report. If a country says they have 100 maternal deaths, that's what I measured, identified in the system. After applying the methodology, more or less the country would end up with a figure of 150 maternal deaths. Afterwards, the countries that do work, the intentional search for maternal deaths and make efforts to improve the quality of the information. For these countries in particular, they can reduce this 0.5 correction factor. Sometimes they can even get it down to 0%, such as in the case of Mexico, which is one of the few countries whose figures are respected. At the end of the day, it's good that we know that these figures produced by the MMEIG are figures used for the follow-up and monitoring of the SDGs, the Sustainable Development Goals. Therefore, so that's another reason that makes these figures even more important for them to be accurate. So about this, and beyond that, what should we do to address this? The first thing we should do is make sure that we have a plan to strengthen the production of maternal mortality information in general, as well as, of course, maternal deaths. We should also try to provide all these solutions that allow us to improve these problems that we just mentioned, ensuring that there are linkages between the different sources, trying to minimize cultural and geographic gaps in terms of registration, training doctors, ensuring the correct completion of death certificates, training coders. This is a solution at the end of the day which we should be applying, but that's a solution that's not going to happen in the short term, and it's not a quick either to implement. So because of that, we have to find an interim solution. That's would entail the implementation and continuous implementation of a methodology to improve the registration of maternal deaths. Having said this, I'm now going to talk about a best practice, which is precisely the one that the Pan American Health Organization, through the RELACSIS, has been disseminating and sharing with the objective of ensuring that countries are aware of it as much as possible and that they can adopt it, whether they adopt it as is or whether they adopt it to their needs and possibilities, of course. This is known as the Intentional Search and Reclassification of Maternal Death, BIRMM by its Spanish acronym. It's been implemented by the Secretariat of Health of Mexico, by the CEMECE, the PAHO Collaborating Center for Family of International Classifications. And for the past 15 years, this has been implemented using information taken from 2002. This methodology, so back in 2003, with information from 2002, this methodology was implemented under Dr. Lozano, who back then was the General Director of Information Systems, and it was excellently implemented by Dr. Luis Manuel Torres, who was the Subdirector of CEMECE, and Mexico now has the fortune to have him as an advisor on this topic. So what is the objective of this methodology? It's to reduce the incomplete registration of maternal deaths and correct ill-defined deaths to obtain reliable figures of maternal mortality. That is, to work with both of the main areas which take us to sub-registration, whether sub-registration as itself or also it will define deaths. So which are the components for this methodology? So the first is the ratification and correction of maternal deaths which were initially confirmed. That is, those deaths which were registered in the format of the death certificate. So these are identified as maternal deaths. That's step one. There was an obstetric complication of some sort, or it was identified that the woman died while she's going through pregnancy, or the puerperium. These ones which we know are maternal deaths. The second component is the investigation of cases suspected of hiding a maternal death. That is, those in which a maternal death was not identified, but due to reasons which we're going to see further ahead are considered maternal deaths, and they were considered suspicious. We have to investigate them to classify them correctly using the Ramos methodology, which we'll get into momentarily. The third component is confronting and comparing with other sources to identify other maternal deaths which were not registered in the information system, the primary one for the country.
And lastly, last but not least, the publication of results and the statistical analysis concerning maternal mortality from the data collected. So to go a little deeper on the first bullet, of course we're not going to get into much detail, but just to get to know a little bit of the practice. Speaking of maternal deaths that initially are coded as maternal mortality, it's important to study them, because even though we do know that they're maternal deaths, many times the cause itself is not included with precision. By that I mean this has a lot to do with the lack of knowledge that the doctor who is filling out the death certificate. The doctor, yes, identified the period of puerperium during the birth, but it didn't specify the causes in detail. So in that way, it is good to have for each one of these deaths complementary documentation apart from the death certificate itself. Regularly, this information arises from maternal mortality committees installed in most of the countries in the region that are in current functionality to discuss maternal mortalities that are initially identified. So these committees are in charge of collecting this information and going case by case and try to recover that information. And as you can see in this slide, the clinical analysis of deaths that occurred within the units, for instance, verbal autopsy. Something that's very important is to recover the product certificate, the birth certificate. If it's live births or fetal deaths, it's important to count on the conclusion from the committee if there is such report. Like such as medical notes that are considered relevant, including confidential questionnaire. So sometimes more than the certificate are required for this type of analysis and procedures. For part 2, once you have this documentation, what's done is to go back and register this death. And by that I mean go back to the certificate and establish what were the causes that led to her death, with all the information that's been collected, and pass along this information for a coding process in order to select the proper underlying cause of death, and by that decreasing the problem that could arise for mistakenly filled certificate. So in that process, 2 coders participate, where each one particularly will code the cause of death and select the underlying cause of death. In case these coders get to a different solution for underlying cause of death, so a third coder will intervene, someone who has more and more knowledge about the specific theme, and this third coder is the one who's going to select the final cause of death. Obviously, if these 2 coders get to the same solution, no further process is needed. But by doing that, we can assure that maternal death, being identified as maternal death initially, can be classified its best way possible. Why would we want that? Because precisely we want to know what led to her death and what type of public policies we have to insert. So it's important to have all the details. The second component, investigation of suspect causes of omitting maternal mortality. Below you can see the description in English, reproductive age mortality studies methodology, that's Ramos. So in Mexico, there's been an adaptation of this process, mainly because of how many maternal deaths occur in the country. So in Mexico there was an adaptation, and in that way not all deaths are analyzed because it's not feasible. What we do is a selection of the cases that must be selected and analyzed. So how do we do this selection? We look at women from the database between 12 and 49 years of age, and within that range, we look for the cause that CEMECE has determined as suspectful. It's many more. So looking at these causes, there is a big suspicion of omitting. So looking at these suspicious cases, something must have been provoked to have those cases to happen. So once you have those cases selected, a request is submitted, a specific request is submitted, additionally to the death certificate. In order to identify if it's a case that we can identify as maternal death or not. within the medical unit, a medical summary is requested. And if this death occurred outside of the medical unit, a verbal autopsy is required. It's important to mention that the connection between these documents and the ones we spoke about before in Mexico, the areas of epidemiology and responsible people for maternal health, they're in charge of collecting all data and all documents, going to the houses of the person who died and make such determinations. The third component that we'd like to talk about is the matching of different sources to try to capture registrations of maternal mortality. So, going on, the third component, speak about the source, how they're linked, and ideally, the country would have a unique level of identification per person to help us link all of these sources. That would be the ideal scenario. However, there are other ways to try to link up these information. It could be the incorporation of an index of population built from other types of data. But well, this would be for another conversation. What is important is that the country find a way to link its databases. And I can tell you this year, this process is being done semi-automatically. So initially, a program is done to try to link up similar data like names and residence, and prior to that and after that, personnel that is specifically dedicated to analyze case by case and to decide, well, yes, this might be the same person, might not be the same person. So it's a very lengthy process. However, it's very important because from here we can detect many deaths that in a different way could have been missed out. So what are the sources that are currently being used in Mexico to make this type of linkage? So, of course, the main source is the identification of maternal deaths.
Also, the source of hospital outpatients, which we know that outpatients are captured when there's a death. We can also identify if that death was treated due to some cause related to delivery or puerperium. This can also help identify a lot of maternal deaths. Certificates of products, live births, or fetal deaths, there's a variable related to the survival of the woman, related to the obstetric cause. Also, one of the things that are done is to take those cases where certificates show that the woman died in the process, but also by crossing the database with live births compared to deaths, This helps identify women which were in the death database without a process of showing an obstetric issue, and which also shows some sort of certificate of a birth made 15 days before the death. This is not even a suspected case, to be honest, but it can only be found by linking different sources. We also do a cross with the official death captured by the official National Institute of Statistics. Questions made related to the pregnancy. Other ones related to health. You should also cross it with external sources, such as NGOs. In the case of Mexico, information is used from the Observatory for Maternal Mortality. All this is done through periodic exercises, which depend on, their frequency depends on the availability of each of these different sources. An example would be when you compare fetal deaths and live birth certificates, you should ideally compare it every month. That's often difficult, so maybe every 3 months. Other databases that are often available only once a year, such as the Mortality database that comes officially from Mexico's Institute for Statistics, CEMECE, or the database of immediate notification, which is available on a daily basis. So it depends on the source. Now lastly, but last but not least, is the part about the publication of results from the process of intentional search for maternal deaths and the analysis of these figures that come out of this process. I'm not going to go into too much detail about the content of these reports. All these reports that have been produced by CEMECE are available publicly on its website. You can find the link here. But the most important thing I'd like to highlight is that if a country does a similar process of intentional search and does not publish it, it's as if it didn't exist and you didn't do anything, primarily because the interagency group we mentioned, MMEIG, should have some sort of evidence to adjust that 0.5 correction factor. So it's very important that information is public. We're a little behind, but this information is available for you to review so you can analyze it in depth. I would like to cede the floor to Mr. Manuel Yáñez, the current director of CEMECE, so that he can help us a little to comment on the primary results that have been obtained from this process, particularly for 2016. Please go ahead, Manuel. Thank you, Aline. These results are the latest official ones that we have from Mexico. That is, we are currently about to close the 2017 cycle, but we're going to present this, which is already completed. So as I was saying, these are the latest results available from Mexico, the official figures for 2016. We are in the final stretch to close our investigations for BIRMM for 2017, but this is what we have available at the moment. So as you can see on this slide, related to women in fertile age, reproductive age. We're looking at women between 12 and 49 years of age. So for the 26th year, we focused on 36,613 deaths with these characteristics in reproductive age, between 12 and 49. So looking at some of the questions in the chat box, we're going to just try to answer these in a little bit, but I wanted to address this quickly. So of these women, we picked out 8,367 for 2016. So of these women, 43% of these were reviewed using our methodology and our vision for how the work group would proceed. The team was built up of specialized matrices, specialized doctors with experience in the methodology of the BIRMM. So based on this initial selection, we discarded 3,596 deaths in women of reproductive age. So a little while ago when Aline was commenting on explanation for why you select suspected cases, so there's the other side of this also. If a woman's of reproductive age, but it's specified that the underlying cause explains all the complications that came afterwards, in that case, there's no need to investigate it further. For example, so diabetes is an underlying cause, and other intervening causes. These kind of complications, well, there's no real need to investigate it further. The same situation with tumors that are malignant, metastasizing, HIV and its corresponding complications. So even though we definitely need a death certificate, using this criteria, these were discarded, all these 3,596 deaths. So therefore, we decided to investigate 4,771 cases. These were the cases where, from the get-go, these were classified as, and confirmed, so these ones, it was definitely needed to reclassify them and to look into which was the cause that the certifying doctor had used. So this is the part of the intentional search that calls for the reclassification of these cases. So this leads to having a more accurate code, which helps us make decisions. So we selected these cases which were considered maternal deaths and were considered suspected. That is to say, considering the Ramos methodology which was adjusted, using the underlying cause and all the different underlying causes that Aline mentioned a little while ago, different kind, specific kind of heart attack, among others, 49 in total, different underlying causes considered suspicious, and also if there was no other variables on the certificate which would have given us further information. That is to say, if the death occurred during pregnancy, postpartum puerperium, or in the last case in Mexico, if the person was not pregnant in the last months, and then we can ascertain that it probably didn't have anything to do with the death. This is what was reviewed, and for this year, there was only one case which was not studied and which was not able to have a perfect investigation. After these cases, we discarded with documentation. This is very important to note. We discarded, from the 4771 cases, we discarded with documentation 3,812 cases. 3,812, that is to say, with these cases which were suspected, using the death certificate, this was something basic. We had to make sure there was a death certificate, but also there was a clinical summary, or at the very least there was a verbal autopsy done with important information which helped determine the case. That is, if there's a woman, for example, of 35 years, and there was the specific kind of heart attack we mentioned earlier, which is one of those cases which Aline mentioned earlier, talking about the quality of death certificates. So in the investigation with the verbal autopsy and the clinical history, we were able to identify there might be an OTB from several years ago. This is important information to determine the death. It also calls for operating in another way to try to improve the correction of death certificates with the doctors, but regardless, we were able to use this information to discard this kind of death, among other characteristics which started arising from the investigation. It's also important to mention that different people are needed to be involved in this from our point of view. So it's important to involve specialists in reproductive health, doctors, specialists as well as generalists. Epidemiological doctors are also important, who are good at capturing information for those which are confirmed from the beginning as maternal deaths, as well as statisticians who can help in the investigation. After these cases are discarded, so this led to a result of confirmed cases of total maternal deaths of 958. That was the number that was confirmed following this methodology. It's really important to mention that for these, there were adjustments made. In other webinars, following, we can present a little further more about this methodology and which were the findings and what can be done with this information. So these 958, the total maternal deaths, 812 are considered for the maternal mortality ratio based on a definition from the ICD-10. As well as from the guidelines which can be given, precisely from the ICD-10, the current one which we are using in Mexico.
It's the basis to determine what should go or not. And in cases that end up being classified as maternal deaths, late maternal deaths, or by sequelae, these would not be included in the ratio, but those that are directly related to the death of the women. And that's why it's important to study in a sense of investigation for cases that have been determined by the doctor as maternal deaths. By that I mean that, and based on the evidence and clinical studies and analysis, it's important to for specialists in reproductive health, and can be determined as and other maternal deaths that have not been considered. And here, in our case, the 958 total maternal deaths that we have as confirmed and investigated. And it's important because, as I was mentioning, and as I read from one of the questions in the chat box, this is for the results from back in 2016. And the first matching we have with the National Institute of Statistics in Mexico, and these are the official numbers reported. In the first revision we did for this year, there were 974. And with the BIRMM process that we used in the Secretary of Health, there have been 484 compared to the total of 958. So for this year, 2016, 51% has been contributed to the official statistics. And if we review details starting from the implementation of 2016, which is the last official numbers, we can see that this contribution is rising. And such numbers are being refined by the methodology. But we would like to call the attention for this contribution, and it's worth noting. Now I'm passing the floor back to Aline for those following slides. Thank you very much, Manuel. As you were saying, really these two slides that he presented during this first webinar, these are only to allow us to see very large numbers and what have been the results of implementing those methodologies. So we invite you to the next session as well that will be held by CEMECE, so we can dive deeper into these results. I would also like to compliment a little bit more and that you watch 2016 this process and the 50% figure we discussed. So this is worth noting, and it seems that the national estimates, at least for Mexico, are not that wrong. And by that I mean, if Mexico did not do the intentional search and reclassification of maternal deaths, the under-registration would have been specifically in the range of 50%. So I would like to leave that as a note, as mentioned by Manuel. In order to get to this 50%, it was an overnight process. It's a process that's been conducted for over 15 years continuously in the country of Mexico. And when they started to be measured, it was at about 25%. and in the previous years, it's been rising, especially due to refining of indicators. And many more deaths have been recovered ever since. And also the linkage of sources has a lot to do with it. And which rose even more with the massive infrastructure of systems in the past 4 years. Well, so since there are not a lot of questions in the chat box, I'm going to take a couple more minutes for the Q&A session so I can wrap up the last topic, which is the contributions of the Pan American Health Organization in this topic. So CEMECE made available for RELACSIS starting in 2014. This practice, in order to be evaluated and disseminated for the countries in the region. So this collaboration between RELACSIS, Pan American Health Organization, WHO, and CEMECE started back in 2014. This URL that you can see, you can find all of the details about this dissemination that was constituted in the work group 9 of RELACSIS. From there, a series of actions are conducted that began with an international workshop conducted by CEMECE in Mexico, in the city of Mexico, back in 2015, where we counted on the participation of many countries in the region, and the results. I would like to note on the results of countries such as Argentina, Paraguay, Dominican Republic, and Uruguay. There have been a lot of a struggle to adapt this methodology and to apply it within their countries, and conduct exercises of search, intentional search. Other information related to this workshop and the presentations are in this URL where you can see on my slide. Other actions that have been undertaken for this topic are this series of webinars that are being conducted during September and October, where the objectives are, on one hand, go deep into BIRMM and Mexico's experience with it, and on the other hand, to present the big struggles and experiences in the countries to duplicate this exercise, adapt it to their own realities. That's why you've already received communication about the further webinars and more details about the experiences and the dates. Also, from the Pan American Health Organization, we're going to send a survey that's been designed to collect every input that allows the Pan American Health Organization to follow with those lines of cooperation, counting on very complete information from the conceptual part of maternal mortality. They especially go through a specific process of collecting data. Also, ending, of course, with a module that counts on information about analysis of information, data analysis, and the actions needed for substantive material. So by that I mean, this survey will be arriving at the countries very soon, and due to its integral character, it's requested that it's filled out by a team consisting of those responsible for epidemiology, maternal mortality, and natal statistics. the other hand, Dr. Patricia Ruiz has already mentioned the second International BIRMM workshop will be taking place this November, where initially it is expected to count the participation of countries that did not participate back in 2015. This team will be formed by responsibles for maternal mortality, informatics, epidemiology, the focal point for health within the countries you see there. Also the focal points, the specific focal points within PAHO for reduction of maternal mortality in these 10 countries. Last but not least, and this is something we have planned in the short term, it's an international workshop specifically for coding of maternal mortality offered by CEMECE in coordination with PAHO in 2019. So we thank you very much for your attention, and let's go on to the Q&A session. Manuel Yáñez will answer these questions if you have any, and we'll be discussing the deeper questions. The ones that are not we're not able to answer, we will send responses via email. We will share with all the participants the answers. So don't worry, all of these answers will be shared. One more second, please. Before we begin, and to start with the first question, I'd like to summarize some of them because basically it'll be 5 comments between comments and questions that are related to the age range considered as reproductive age. We all know that there is a range established by the WHO that's between 15 and 49 years of age. Specifically for BIRMM, though, it's been decreased to 12 years of age, to begin at 12 years of age. So, and it's even been discussed to begin at 10 years of age. However, the false positives were a lot, and at the end, we were doing it beginning at 12 years of age. But the established age established by the WHO is 15 years of age. With that, I think we can answer a lot of the questions that have been posted here. I'm going to read some of the questions and comments that I have over here, starting from questions by Victor Gonzalez from INEP. I don't know where he's from.
Good morning. With the question that Carlos made, making these figures official, at least in Mexico, we have the publication of official figures comes from the INEGI, the Statistics Office. Thankfully, in our case, I think the sound is better. They're going to repeat the question. So, you're working as an organic section within the Ministry of Health, working on civil registries and the Institute of Statistics within the region. This has often led to multiple issues. There are legal frameworks and methodological references that allow to systematize and address these issues with the necessary frequency to guarantee coverage and quality of maternal mortality. So Manuel is answering now. So here in Mexico, the INEGI is responsible for publishing official figures. The INEGI has a statistic and geographic information system, and this system has the opportunity to compare information from different government sources of information, which generate information, such as this case from the health sector. There have indeed been, as we demonstrated the results from 2016, there are indeed cases also considering similar point between underlying causes of death, but looking at the 51% in which the BIRMM methodology contributed towards the official figures to the INEGI, what this really required was a coordination between different institutes, between health and statistics office. In Mexico, we have the advantage that this coordination exists, and even the same vision of collaborating, and these work together. This contribution is not just from the INEGI. In some cases, there are even issues where they debate and they discuss the codes which came from the health sector. Finally, a consensus is reached, and they reach an agreed upon figure. So here, as Carlos asked, I think what's important to ask here about the legal frameworks in your country, these should be addressed so that they can create an environment that allows us, and it also will let these different government instances work together. I imagine that they exist, and if not, then they will need to be created. This will create an opportunity to improve the information on maternal mortality. The next question from Victor Gonzalez from the INE. Considering the frequent rotation and technical weakness from personnel at the local level, rural areas, indigenous areas, etc., in some structures related to the registration and validation and follow-up and processing of maternal mortality, there are proposals for information that could come online on the BIRMM methodology with case studies or other tools that could help implement the methodology. So I think what he's asking, what Victor's asking here, is to be able to get to these areas, he's wondering if there's some proposal that could be done online to help implement the BIRMM methodology. So the answer to this could be, it really depends on the geographic distribution of each country. For example, replicating the case of Mexico, where there are some states Other countries have departments, it varies, and each of these geographic levels have different responsible institutions. So these different subnational levels have responsibility to train these responsible people to go to these more isolated locations. So in an ideal situation, there could be tools which could be more concrete, specific, to address communities which could be targets of the BIRMM methodology. There are examples of health caravans with reproductive health as one of their services. So these are sometimes paid for by other institutions within Mexico's Secretariat of Health. This is a coordination that happens within the Secretariat of Health. For example, these health caravans target indigenous communities or isolated communities. They'll often do a census of pregnant women, and there'll also be a follow-up with these pregnant women. We should also recognize that we have even identified some deaths which were not in the initial figures collected by the subsystems of information. However, thanks to these health caravans, we were able to identify them. And keep in mind that this had nothing to do with the Department of Health Information. It was indeed related, but it was organized by another unit within the Secretariat of Health. And that's how the death was reported, and that's how we can count it. So the coordination within the same Secretariat of Health is very important. Each country should identify a program with the same vision to reach every last area within a country. It should exist, and if not, then the question is how to create it, because it's not just a matter of counting maternal deaths, but also the care given to women in pregnancy, and to ensure that the pregnancy can happen successfully. Another question from Lian Torres says that in the exercise that was conducted, they compared with demographic and health surveys, or do they only compare it with statistics from official institutes? The answer from Manuel, not only with official statistics, and yes, of course, the INEGI and the health sector have their figures, but also, as I answered to the prior question, there is an NGO here in Mexico called BIRMM. They have a strong reach in isolated communities, and often they have information, not always, not every year, but they have contributed with important information that they have available. And this is a clear example that it doesn't necessarily need to rely on only official information. This Observatory of Maternal Mortality, this NGO we mentioned, has certain characteristics, and some aspects are subjective. But they do indeed give important information, and they benefit also from this. They use the information that we generate, so it benefits them. Now this is an NGO again. So it's a clear example of how we are working to address these areas, and also how we're trying to replicate the successful experience. We do recommend that they consider these things as they apply it to your own countries. It's also important to consider that often these figures are not counted into the final figures. Another question. Concerning the results that Manuel presented, I would like to know, the over 36,000 deaths initially identified, had there been a prior cross of information or only mortality statistics? And to look at this 26%, was there a random sample? Manuel answers, deaths of reproductive age women, the range from 12 to 49, were obtained from the subsystem of deaths of the Health Secretariat. Okay? And what was the percentage they asked for? 23%. If the 23% that was selected was due to a random sample. He answers that no, they took all the reproductive age women, and from there they select a first selection, a preliminary one, based on certain criteria. As we were discussing, this total universe, they select those that enter within the modified Ramos for suspected deaths, or maternal, whether they call attention or whether the underlying cause specified does not clearly specify the death, or those that are discarded for clinical medical reasons, in which there is certain agreement between the causes of death and the certificate, and it is not necessary to investigate them further or to do an additional investigation or document investigation to determine. Now, even though we know that sometimes the registration is not the best, but we do recognize that in some cases, some certifying doctors do actually do with good qualities, so this is important. So, starting with reproductive age women of that age range, that percentage that you asked about is based on that determination. From a clinical medical perspective, they look at the underlying causes, and if it's not necessary, then those are discarded using the judgment of the specialized. And that's how they ended up with the number of those that they do decide to investigate. Now, this is to note. We look at confirmed and suspected, and that's how we get the most detailed information we can. Thank you, everyone. We got other questions and many comments and reflections in the chat box, and we are greatly appreciative. All of this will be responded to. All of your questions that went unanswered, we will respond to them. We will send them to you. I would also like to take a minute to close the session with a reflection. So, as we said at the beginning, we need to count all maternal deaths. We need to ensure that they are well classified for statistics. But there's something else that we need to work in and ensure. We cannot forget to identify which were the factors that contributed so that the maternal death happened. That is, a maternal death that happened due to hemorrhage. Really, the cause of the death is not the hemorrhage, right? The cause of the death was that there was not a network of safe blood. They did not know how to apply a certain process to stop the hemorrhage. So I hope I explained myself well. I just wanted to clarify this. I didn't want to leave without saying this, because it's very important that besides just ensuring that we have the cause of death based on this ICD, this process, it is very important to ensure that we work on these other factors, which at the end of the day are the ones that lead to the maternal death. Well, thank you, everyone. We thank the team of RELACSIS from PAHO CEMECE for your attention. And we're waiting, and we will see you on Friday at the next webinar. Thank you, everybody.